new symptoms. And I'll just revise what we have discussed before. We said that patients will be presented to you with a chest pain. The first thing, of course, you will approach them with taking a history and assessing the types of the chest pain. Examine the patient. Usually may not be that important and significant as those who comes with this chest pain, but of course you will look for signs of heart failure. You will look for signs of, for example, aortic stenosis, which will present the same. And of course, doing serial enzymes and ECG. And after that, you will end up with either one of these three results. Either you have a patient who have an ACS, and then you know, of course, how to deal with that. And then, or the pain is non-cardiac. The third option, which is the suspected coronary heart disease, according to your pretest probability, you will divide those into low risk, intermediate, and high risk. And then with all these modalities you have, starting with exercise ECG, through echo, MBI, CT, MRI, and all these, you will establish the diagnosis, of course, of coronary heart disease. It will guide you as well for the management and give you prognostic information about your patients. Now, this is for those who are not having a ischemic heart disease before or coronary heart disease before. Now, those with stable coronary heart disease, who already you diagnose them and you know them that they already established disease, still they will need these tests, of course, not because of the diagnosis, for the prognostic wise, or if they develop the new symptoms while you are following them up in the clinic. So it's applied the same, actually. The patients with a stable ischemic heart disease who are able to exercise and having interpretable ECG. Again, here, this little modification is that this is the same applies for those with intermediate risk. So the exercise ECG will be class 1, exercise echo or MBI will be class 2A, and cardiac CT is 2B. And of course, pharmacological test will be class 3, since the patient can exercise. Those who are able to exercise and having uninterpretable ECG will go for exercise imaging, pharmacological stress MRI, class 2A, and cardiac CT will be class 2B. Now, let me start with a scenario and let's see what how we will do. You have a 45-year-old male who is known case of hypertension. He's a smoker. He had a family history of a mother who just died 1 month ago at the age of 60 due to an TSTD. He came to you to the clinic. He was grieving and sad, and he's concerned about that. He will have the chance. What are the chances that he will die from the same disease, and what should he do? And he's like an educated man, and he just came from abroad to attend his this event. So how will you approach him? He's sitting with you in the clinic, and this is the scenario. So how would you deal with this guy? Hello?
Yes, you are firing, Dr. Majid. Okay, this patient, he doesn't complain of chest pain. He's just asking about his fate. First, I will show some sympathy about his mother's death. I can calculate the cardiovascular risk for him, and then to discuss what's next to be done.
What do you mean by the? So you will okay. What do you mean by calculating the risk? What kind of risk you calculate?
Atherosclerotic cardiovascular risk score.
Okay, perfect. Then, so before you assess it, before you you assume that he doesn't have symptoms.
He's just concerned about. I can take some history.
Yes, you should actually, right?
Yes.
So you took in a history actually, and he denies that your history will be directed toward the symptoms of coronary disease, especially
yes.
Whatever it is. So you have to be systematic in a way you approach him. So you took in a history, and after you took a history, what else? Number 2, you will calculate for him the
Before or after?
After history now, you calculate for him
the cardiovascular risk or atherosclerotic risk score.
Okay, and then number 3, what you will do?
You have to examine him.
Examination is remarkable. He doesn't have it. So apparently he's a good man.
Okay. Then, according to the score of the risk, according to the risk score, if it is low or moderate or high risk, then I will do my next step.
Which is?
If it's high score, I should put him in medication. If it is low score, I can follow him, only follow him.
What do you mean by medication?
Okay, if the risk is more than, I think 10%.
7.5.
7.5%, I should give him high intensity statin plus aspirin. If it is low, no need for medication or no need for aspirin and atorvastatin or statin in general.
Anything else you need to send for investigation? And you took a history, you calculate a risk. His examination was unremarkable, or nothing there. You didn't take it. Any part from the investigation wise, usually it is like history, examination, investigation.
Yes, I think yes.
Profile.
Yes.
ECG first.
Sent for lipid panel, right?
Yes.
Now, according to that, fine. So you said you will assess for him the atherosclerotic cardiovascular risk score. These are just elaborating about the parameters that you will enter. It likes it's an app nowadays, and you just put these inside the apps, and they will come up with the. Of course, you will not. The difference here is you will not calculate for a patient who is already a known case of atherosclerotic cardiovascular, whatever he's having, peripheral vascular disease or cardiovascular events or stroke. So you will not calculate, you will not apply this risk. And the other question that they will ask you usually, what is the aim of the risk? What this risk actually score reflect what? Usually it's reflect four things: the risk of having a non-fatal MI, coronary artery disease, death, fatal or non-fatal stroke. This is actually what the risk is about. Okay. Now, what else you will do? You sent for him. Now he has any symptoms suggesting coronary artery disease, and he has no history of diabetes. And the results of the lipid profile came to be as follows: LDL is 130 milligram per deciliter. His total cholesterol is 200, and his atherosclerotic cardiovascular risk score is 9%. What's next? Any ideas? You can share whatever you have in your mind. You can tell.
Okay, he has a high risk of atherosclerotic, and also his total cholesterol is high.
Right.
So I have to give him high intensity statin.
Okay, high intensity statin. Any other thoughts? Now, let's take it from the beginning. Usually, when you assess a patient like this, and we said the algorithm starts with the age, of course.
Yes.
From 40 to 70. Okay, and then you will assess the either the patient is having. It will be categorized into like 4 groups: those who already established coronary artery disease or atherosclerotic disease. It doesn't apply for them. This algorithm, I mean, the one you will calculate this risk. And other group who is diabetic. That's why I stressed here that he has no diabetes.
Diabetes, yes.
Because their way of approaching is different. And then you have a patient who are having. He's not diabetic, having any other sclerotic disease before, and according to his LDL. Now, his LDL, if it is between 70 and less than 190, because if it is more than 190, this is different scenario.
Yes.
Think of the
Yes.
okay. The risk here or the score is like between, now what are the categories of this score itself? You have a result of less than 5% or from 5 to 7.4
5.
or
Okay.
from 7.5 to 20 or 19 and then above 20. Here are my categories, okay? Those who
Okay.
are less than 5%, they are doing
It's
fine,
low
nothing there. Yes, it's like lifestyle modifications. Those who are in the category between 5 to 7.4 or from 7.5 to 20, those two groups are like an intermediate, okay? Anyone who's above 20, those will get indicated
High risk.
high risk who needs statins, high intensity. This
Okay.
group, or at this stage, what you need actually to do according to the guidelines and the algorithm here is okay, you will argue with him that you want to start right now a statin. And you have to be very specific in terms of the statin, which is if it is a moderate statins or high statins, right? What is the
Yes.
difference between them? Moderate and high intensity? What do we mean by that objectively?
The high intensity statin that the daily dose should reduce the LDL cholesterol more than 50%.
Okay, and the moderate
And
one?
the moderate reduce the LDL cholesterol by
30%. Fine. This one, he's between 7.5 and less than 20, so he deserves to be on a moderate statin, right? But he's arguing with you now that he doesn't want to start the medication, or he's afraid that the medication will cause for him harm to his liver, or wherever they will get the side effects of the pain. And is it really cost effective for him to stay on a medication? At this stage, what you will do next to convince him? Any other modality came to your mind that should be done? Would you do ECG, ولا echo, ولا CT, ولا MRI, ولا MBI?
CT coronary angio for scoring of the calcium.
Okay, it's okay. You start with it's a CT for coronary calcium scoring, right? Not CT coronary angio, and we will discuss that in a minute. Right now, the patient underwent a CT for the calcium scoring, and the result came as follows. The number is 150 Agaston unit. What's next? You just brought you the
Coronary.
result.
Coronary angio.
No.
This is low risk. If it's less than 400,
Okay. No. But any other thoughts? How to approach this number? But the answer will be is that
Positive.
okay, now this number actually indicates that he should be started on moderate intensity statins, because you have an image or the score that present he's having a deposits of calcium, which most likely will present a presence of a plaque. And this is like an objective assessment you can show him in order to start these statins, okay? Now, this is the algorithm that I've been talking about. You start with the primary prevention for those people who are 40 to 75 years of old, and they're having an LDL between 70 and less than 190, and they're not diabetic. And then you assess for them the risk, the 10-year risk score. If it's between 7.5 and 20, then that's mean the intermediate. We said if it is less than 5, they are low risk, you just lifestyle modifications. Those who are between the 7.5 to 20, they are intermediate, who you will need a further assessment. If they're more than 20, then this is clear. You evaluate what we call the risk enhancers, like lipoprotein or the high reactive C-reactive protein. You need to go to the details, and later on we'll discuss the dyslipidemia and all these things. Now the calcium scoring, this is where you need to understand, if it is the calcium scoring is like 0, there is no need for a statin unless the patient is diabetic or having clear history of coronary heart disease or history of smoking. If it is between 1 to 99, it favors the starting of statin, especially if they are more than age of 55. If it is more than 100, then you need to initiate the statin, which will be here in this case the moderate intensity statin. This is a common scenario, comes usually, basically will not in the exams or in the MCQs usually, but as well as in a clinical station can come like this. So you have to understand the clinical significance of a calcium scoring. You know that, okay, there is a calcium scoring you will do, but you have to understand then what else you will do after getting the result, which is the category here between 0, 1 to 99 and more than 100. Like, how about stress testing a people or a patient who is asymptomatic, and that you want the same patient who came to you, like, and he has no symptoms at all, and you want to assess him with the same modalities that I mentioned before. So is there any role of exercise stress testing? Would you put the patient or send him that, okay, I will send you to do an exercise ECG? Usually this has a class 2B for a patient intended, especially if they are going for a vigorous exercise program. And still it's like being criticized, not well validated. Like now they have put it like class B, those who are asymptomatic totally, and they have like intermediate risk based on the atherosclerotic cardiovascular risks. And they are willing to go for a vigorous exercise program, or you are advising them to go there. So this is a class 2B. How about doing a stress echo for them? Definitely no. Myocardial perfusion scan is well the same, is not indicated, of course, class 3 to do for those who are asymptomatic totally to assess just the presence with the risk of coronary heart disease. However, if they are very high risk category, like those who are diabetic and very strong family history of coronary heart disease, and you did for them the risk assessment and came to be very high, and the calcium scoring is more than 400, those are the patients who you may go for myocardial perfusion scan. It carries a class 2B. Okay. Now, the CT or cardiac CT. You have two things in the cardiac CT: the calcium scoring. This is an entity, and then the other thing is the coronary artery or coronary angio. The calcium scoring is the one which is very quick testing. It's not expensive. You don't need any contrast here. And it has a powerful prognostic data, as we said. And the coronary artery CT or angio, you may evaluate here the luminal part of the vessels. And of course, you will assess the presence of the plaque, which is either we do have the calcified and non-calcified. And you will require, of course, here an IV contrast. Third part now is what we call the multiphasic CT. You evaluate the chambers and the functions. We don't need it now. Like these are the two main important, which is the calcium scoring CT and the coronary angio. This image represents, as you can see, this is the one with the contrast, is assessing the vessels of the lumen, the one on the right, and the one on the left is the calcium deposits. Okay, and by the way, having a calcium itself is not a harm. It's not like it's okay to have a calcium deposit. Like the main importance behind that is that it will reflect that they have more likely they will have a plaque in their vessels. So a CT is a process which is usually started with the patient preparation. We give them usually beta blocker and nitrogen to dilate their vessels and to lower down the heart rate, because what we call, I will not go to the technicality part of the CT, it's like we call it the ECG gated CT. You need to lower down, so you will, because you are actually taking an image of a moving object. Now the image acquisition itself is very fast. Then the next step will be the reconstruction, usually in done by the technician, and now the interpretation, which will usually be by a radiologist or a cardiologist. Now, the contraindication of a CT, you will not send people who are obese or BMI of more than 40, and those who are already having an extensive coronary heart disease, or previous stents, or those with allergy to the contrast. This is an image of the calcium deposits. You can see the one on the left having small deposits, which is giving a calcium scoring of 14, and the one on the right is extensive deposits and giving a calcium scoring of 288. So this showed that the amount of the the calcium deposits is actually proportional to the event rate, so as much as you have, dose related actually, or I can say the event rate actually is dose related regarding the calcium score. Now the coronary angio is requiring a contrast. It detects the presence, mainly you are now seeing the presence of the plaque, and you grade the luminal stenosis of the coronary artery. They grade it from 1 to 25%, it's like minimal, and then 25 to 49 is like mild, 50 to 69 is like moderate, and severe more than 70%. The image on the right one is showing an LAD, where after giving the first diagonal, you can see that there is a stenotic lesion in the LAD, and this is proportional when you do a coronary angio. This is the mirror of that in the coronary angio. So it showed how it is very sensitive and specific there. It has the advantage of the CT, it detects a wide spectrum of coronary heart disease, from a very mild one to the very severe stenotic coronary heart disease. It's the difference between a CT and the other modalities is that if you did a functional study with the MBI, or we put a patient on exercise ACG, those tests usually, if they came to be negative, because they measure the obstructive lesions, or it's the cut point of the obstructive lesion will give you the positive results. However, in the CT, it can give you the presence of the plaque itself, even if it's a very mild and from as minimum as it could be. And this one, if you test them, they might get a negative test on, for example, a stress echo or stress ECG. However, if you put a CT or send the patient for CT angio, it will show that they have the plaque. So that's why the sensitivity of the test is very high, it's 97%. Now, what's the importance of getting or detecting a plaque in the vessel? We know that actually from the study that done in Scotland, they found that when they randomize the patient to those with the standard of care, that's the people who get into the exercise stress testing, and if you add to them a CT and you picked up a plaque, for example, and by the event rate there is a reduction in the event rate by more than 41%, because those who you will detect the plaque in their vessels, you will modify their treatment. You will be aggressively treating them in a way of the prevention part, in compared to those who go to exercise testing and you just treat those who give you a positive test, and this is the rationale behind the results. So now the current guidelines in the European is like it gives a class 1 indication for initial starting with a CT for those to diagnose a chronic coronary syndrome, and even for it's class 1 indication for those who comes to you with ACS, or of course the low risk people with, for example, unstable angina, you will need to risk stratify them. They can do for the CT. What are the limitations of the CT here is the lack of the functional significance. You can see the lesion, you can of course quantify it, like in terms of how it's significant in the functional significance of this, especially for example the moderate lesion. If you have like 60% lesion, you cannot say that whether this is significant or not. You will need a further test like MBI or stress testing. However, nowadays they do have the CT FFR. They can do functional flow reserve in this CT as well. So again, what do you assess in a CT? You start with the calcium scoring first, the degree of the luminal stenosis, you grade it, and the more important thing is the high risk features of the plaque. It can give you features on a CT like what they call it a positive vessel remodeling or attenuation plaque, etc. There's specific criteria there where you will tell that this plaque is having a high risk. And we know the importance of this. The plaque itself, you can have the plaque of 70% stenotic lesion and another one of like 20%. But they found that those who comes with the ACS, with half of them are actually having a non-obstructive one. It means that you need to know is this is a high risk plaque that will rupture, that will cause for you acute coronary syndrome or not. So you can tell this information based on this plaque features if this is very high risks or not. And of course, now I said the hemodynamic significance of the CT. How do you interpret the results of the CT? Usually you grade it from normal one, they call it coronary disease or reporting and data system 0. Those people you will reassure them, of course. And then you do have the one with the minimal and the mild, minimal between 0 and 24, and the mild is like 25 to 49%. Those people usually you go for preventive therapy. You just assure them and you activate their, you give them the preventive measurements. And then you have the lesion where it lies between 50 and 69. Those are having the moderate lesion, and the severe one, which is more than or 69 to 70. Those categories need further management. And this is the same applies as I discussed before in the, for example, the exercise ECG. Whenever you have a moderate test result, then you need to further assess it. If it is a low or high, it's easy to deal with it. If it is like in the moderate range, then now you need to further assess the patient. And this is actually happened in in coronary artery disease reporting and diagnostic or grade 3. Those people will consider functional assessment in terms of either send them for MBI or exercise test. And those who with this more than 70 or severe stenosis, you will consider for them, of course, the coronary angio. If they have left main more than 50 or 3 vessel disease more than 70, of course, intracoronary angiography is indicated. So whenever you have a test, CT report, don't jump direct to the cath or say that angio. If you have a high coronary calcium scoring, don't jump mindset to send the patient to cath. You need to know how to interpret these tests and how to interpret the calcium scoring and the. So by this, I just concluded. I didn't want to give a long lecture actually, so people can concentrate. Any question?
Thank you so much, Magdi. Thanks a lot. Do you have any questions?